on this subject of HIV, pregnancy, and pre-exposure prophylaxis. So I'm Dr. Greg Felzien. I'm an infectious disease physician, board certified in internal medicine, infectious diseases, and certified through the American Academy of HIV Medicine. In my recent career, I have moved to the position of the medical advisor for the last several years for the Division of Clinical and Medical Services at the Georgia Department of Public Health. So I want to jump right in. I'm going to share my slides. So like I had said, this is a real hefty topic to cover in a very short period. So we're really going to hit some highlights and some new developments, updates in the guidelines, and what we can kind of think about maybe the changes of therapy in the future as it relates to HIV and treatment and for prevention. And we really do want to focus on women's care and HIV. So I want to show some statistics and really get into why is this important, whether you're in an urban center or in a rural center. So even though the objectives are very short, there's 3 of them, we could really spend the rest of the day talking about these subjects. So we really want to keep in mind that you will have availability to the slides, and many of the slides I left in just for reference, and we will not be going over those in any detail. If questions come up after the presentation, if you're here live, we can cover those as time permits. And if you're watching this as a recording, please reach out and we're happy to answer those questions. So just a really quick overview. I know many of you are HIV providers. You're not new to this, but those that may be new to this, just as a reminder, at the end of 2018, we had an estimate of 1.2 million individuals with HIV in the United States and nearly 38,000 new diagnoses. But one of the things that we have to keep in mind with data is I've always found it to be having the potential to be stigmatizing in of itself, because I have many providers that believe HIV is only a young Black African American men who have sex with men disease, and I have to remind them, well, that's where the epidemic really sits right now. But if you look at the data, HIV affects all age ranges, as you see on the left-hand side of the slide, and if we look at the Black, African American, Hispanic, Latino populations, this is where it is really hitting them the most, is in these races and ethnicities. But that doesn't mean that nobody else is being affected by HIV. So when before COVID came out and I traveled, I used a lot of mass transit to get around the larger cities where I was having conferences, and really was looking at how they were marketing. And sometimes they were marketing well, and other times they were really focusing only on that population. And if you looked at the people riding transit, there was such diversity. So you can imagine someone who's Asian or Hispanic or Caucasian, et cetera, looking at these posters that are really targeting young Black African American MSMs. There's no connection, and they feel like they're not at risk. But we know that there's risk there, and HIV is blind to race, ethnicity, sex, etc. So when we look at these new diagnoses in 2018, Black African American women through heterosexual contact really make up a large percentage of those new diagnoses. This also includes Hispanic women, Latinas, and then you can see the white women heterosexual contact at 958. So the whole point is these are not zero. These are not just 1 or 2 cases, but a significant number. And if we look at women specifically, 85% were reported as heterosexual contact. We know that there's an injection drug use, there's an opioid epidemic going on. So we really also have to ask those questions when individuals are in the office, and we really want to kind of take take a better history and take those times. I have several individuals that come in. If you look at them, you would think, oh, this person is not doing X, Y, and Z, and you start to do an exam and to come to find out they're injecting between the webs of their fingers, the webs of their toes, trying to hide the injection sites, and they do have a substance use disorder that really needs to be addressed. So if we bring this home to Arkansas, and one of the reasons why it's so important to do this, so if you were to go out and do a presentation in Polk County, you really want to show Polk County information, because what I have found across the board is it's always interesting to see national data, state data, but there seems to be a lot of bias when you show that data, meaning that, there's 1.2 million individuals with HIV in the US. That must be New York, San Francisco, Miami. That isn't us. Then you show state data, and then they start describing, oh, it must be the large cities. It must be the urban areas. That's where the issue is. But the CDC put out a report just last year that stated in the southeastern part of the United States anyways, 26% of new diagnoses are occurring outside of metropolitan areas. So that is a huge amount. So it's not 1%, 2%, but just over a quarter of the new diagnoses are happening outside of those urban centers. So we have to keep that in mind. The other thing to keep in mind is really looking at what's occurring across the state. You can see in the bottom right, the perinatal exposures for individuals acquiring HIV, 2 in 2017, and really that should be 0. If we're getting to 0, if we're ending the epidemic, we should be at 0, and these are sentinel events, and we should really be discussing what happens. And we've had facilities here in Georgia where we've reached out, and the OB made comment, oh, I don't screen my clients because I don't take care of that population. So that's not an issue. So to really educate that STDs are across the board, and we have a very mobile community. I know we've been in shutdown with COVID, but we're seeing more and more people getting back to normal. They're very mobile. They're going back to the big cities to enjoy what they offer, and many times acquiring sexually transmitted infections while they're there. The other thing that was reported in Arkansas in 2017, if you look at the top of the slide, is new diagnoses, 15 to 17% new diagnoses occurring in women throughout the state. And again, the majority are in Black non-Hispanics, which I find very interesting with the next slide when I show some more of your data, that some of your data really is very reflective of what's going on in the culture in Arkansas. And if we look here, if we look at prevalence, this isn't new diagnoses, but individuals currently with HIV, that women make up just over 20% of that population. But if you look down at race and ethnicity between white, Black, non-Hispanic populations, they're pretty equal. So you saw new cases are mostly occurring in the Black African-American population. So we might see a change in this data down the road. But currently, it's 45.6% for the Caucasian population and 44.5% for the Black African-American population. And of course, throughout the years, there have been continued cases of perinatal exposure with a total of 37 individuals as far as prevalence goes. In 2017, you had 2 new cases. So again, sentinel events should be investigated and evaluated. So again, if I was in one of your counties giving this presentation, I really want to drill this down and show that data, because we still have providers practicing in rural communities that believe that sexually transmitted infections across the board are not an issue in those rural areas. So just as a reminder, the treatment guidelines for naive clients has not yet been released. We keep waiting for those. Everything else to be released. But just as a reminder that a couple of things, treatment has become much more simple. The boosted regimens with cobicistat or ritonavir have dropped out of the recommended for initial regimens because of drug-drug interactions, potential side effects. Medications that contain elvitigravir, which is Gemvoya, Stribild, have also fallen because we found they're less fit. You experience greater chance of mutations and resistance with those medications compared to the non-boosted integrase inhibitors, but we also have to be cognizant of the individual that we are caring for, meaning that if we're thinking about a regimen, if you look at the top right of TDF, FTC, and raltegravir, well, raltegravir is taken twice a day. Well, there is an HD version, Icentris HD, which is taken once a day, but it's 2 pills. And many of the clients I serve will come back with the TDF FTC bottle empty after 30 days and the raltegravir half empty or half full, however you see the world. Meaning they couldn't understand, why do I take 1 out of here and 2 out of here? So I just took 1 out of each bottle, and that's what I took. So they really think about that and not just assume that as such, because individuals do get pill and bottle fatigue. The 2-drug combination with dolutegravir 3-TC did make it to the initial regimen options, but again, we just can't hand this medication out without understanding the clients we serve, meaning that is not FDA approved for individuals with an HIV viral load of over 500,000. It should not be given for an individual with a known M184V, or we don't know what their mutations are, because the M184V would knock out the 3-TC, and now we're left with monotherapy. And also somebody with chronic active hepatitis B. Does 3-TC treat Hep B? Yes, it does, but you do not give it as monotherapy, because within 5 years you will have 80% resistance. So you either have to add entecavir to this regimen, or really give something else that treat hepatitis B, such as the combination of TDF FTC or TAF FTC. So why do we want folks on therapy? Well, without therapy, it increased harmful impact of ongoing HIV replication. We want to prevent secondary transmission. And this is an old slide. It says 96% reduction, but I'll show you the updated information. But again, we don't want to write prescriptions just to make us feel better so we can sleep at night, because that can be harmful if that individual doesn't understand the ins and outs and the importance of the adherence of taking these medications. So if there's other clinical or psychosocial factors, let's jump on those, and jump on those right away. Let's not have that client wait for days or weeks before they see somebody to have these discussions. Because if we look at the trials, treatment as prevention, this was a public health benefit. And also the START and Temprano studies, early treatment, individual health benefits. And I'm going to show you some information from the CROI conference 2020 that really showed this. So we've really moved into that era of undetectable equals untransmittable, and to really stress this, but also have an understanding of it, because I still have individuals that believe that U equals U means I can't get anything. And then they're surprised when they come back with gonorrhea. We're treating them for syphilis, and they thought, oh, I thought if my viral load was undetectable, I didn't have to worry about this. So it really falls back on taking a deep breath and saying, we needed to do a better job with education, making sure that that individual understood, the discussions that we were having. The other thing that I like to show is that clients will come in, they're newly diagnosed, and the number one question that I get over and over again is, look, how long do I have to live? Do I need to get my affairs in order? And I've been caring for individuals with HIV since 1992, and back in the early and mid 90s, I was a hospice provider. The therapies just were not as good as what we have today. So if you look at life expectancy, and this is that study from CROI 2020 that I just mentioned, if I have somebody age 21 diagnosed with HIV, and their CD4 counts above 500 in this abstract that was put out, and they remain adherent, there is no gap in overall life expectancy. That gap is gone. But the thing that we have to remember is the comorbidity-free life expectancy. There's a 16-year gap. So if we look at national data, in Americans, that is, Americans typically start to develop comorbidities on average. Life's a bell curve, but on average at age 50. If someone has HIV in this scenario, they would begin to see comorbidities, because we're still seeing some other issues with with disease processes at age 34. So there's a 16-year gap in comorbidity-free life expectancy. So we have to keep that in mind and really think about that in the clients we serve. So let's jump into pregnancy. And when we think about preconception counseling, of course, we want to have those counseling of women of childbearing potential, but men will come in and they'll come in with their male partners. I still have preconception counseling. What does your life look like 5 years from now, 10 years from now? And many of them want to get married, the couples I take care of. Many of them want to have children. And I always ask them, how do you plan on doing that? Are you going to adopt or foster? What are you going to do? And surprisingly, I get that question. I get the answer of, well, we have this high school friend and she doesn't want to get married, but she wants to have a child and be a part of our family. So one of us is going to have a sexual relations with that individual, and we're going to have a child that way. And I kind of think about that and say, well, are they aware of your status? What's their status? So bring them in. Let's have that conversation in a kind of a safe environment where we're not judging individuals, but we're really talking about how can we do this safely, because we don't want babies born with HIV. And this is old data. This comes from the OBGYN literature, but it still holds pretty true today that, if we look at preconception counseling, it's occurring in less than 20% of the time when folks are coming in and being evaluated. The other thing we have to keep in mind is timing. So we don't want somebody to find out about their HIV status when they're in the late stages of pregnancy, because suddenly this is where we have the highest transmission percentages, as you can see in this Lancet article from 2006 of 50%. So we really want to make sure individuals are being screened appropriately and know your state laws. So here in Georgia, when Governor Deal was in office, law was signed and enacted stating that any provider that accepts the care of a woman who is pregnant is to offer screening for syphilis and HIV at the time they come into care and during the third trimester. And we prefer 28 weeks because that does give us time to complete therapy for syphilis if we need to give the three shots, weekly shots, and it gives us the opportunity, excuse me, to start HIV treatment. So depending on what you do, if you are the provider taking care of somebody with HIV, it's a very extensive evaluation. So I'm not going to go through all this, but if you're not giving that care, at least understand the screening process, how to counsel somebody doing the screening, and then if they screen positive or continue to have risk, referring them to the appropriate provider so they can continue that care. Because I've had individuals do this, a couple of $1,000 workup, and then they're referred, let's say, to a Ryan White clinic, and then Ryan White clinic does the exact same workup. So we really just want to get them into care as soon as possible. If necessary, do immunizations, and of course have a team approach. I still get phone calls at least once a month. I have this woman, she's crowning, she's going to give birth soon. We just found out she has HIV. What do we do? And I'm thinking, oh my, if we could just go back in time, that would just be wonderful. But let's deal with the situation and move on. But we need to have this team approach because there are so many things that can go right and there's so many things that can go wrong. And I'll mention a couple of those as we move forward. So every woman that is with acute or chronic HIV needs to receive or continue antiretroviral therapies. And we know from old data, the sooner the better. So that's so important, and we've shown over and over again with data, and I'm going to show you some out of Ireland, the UK data, that really show that you can drive this down to almost zero as long as mother is in care, adherent with their ARVs, is on a good regimen, remains undetectable throughout their pregnancy and at delivery, doesn't breastfeed, and all of a sudden we can drive this to near zero. So we know if somebody comes into my office, let's say the OB calls me and says, I just diagnosed somebody with HIV, can you see them today? And we try to make every effort we can to see clients that day, because we don't want to wait a week, 3 weeks, 6 weeks, 3 months. Suddenly they fall out of care. So we can start a protease inhibitor or an integrase inhibitor without resistance testing. We draw it, and then we might make changes down the road based on that, but we want to get them on therapy. And then we want close follow-up. The guidelines talk about, oh, you can see a pregnant woman with HIV every 3 months, but okay, you can as long as everything's going right. But so many things can go wrong. So I like to have my staff touch base with that individual every month. Of course, if we're starting therapy, we want them back within 2 to 4 weeks per the guidelines, checking their viral load. Are they responding? Are they having problems picking up their medications? What does that look like? So we really want them to come in every month, have that discussion, or have a phone call. As long as they're touching the system in some way, because we found the population I serve, their situation can change drastically on a dime. Suddenly they lose their job, they lose their insurance, they're in an abusive relationship, they're kicked out of their home. There's so many things that can happen. We want to have that conversation. And there's a growing number of medications we can use in pregnancy. Of course, the abacavir, the ABC that you see, we don't want to use unless they are proven to be HLA-B 5701 negative. So that does take time in some of our clinics to get that back. So we still use a lot of TDF-FTC. We do use dolutegravir. I'll show you the updated data. We also use a lot of raltegravir. And you might ask, well, why not the protease inhibitors? Well, I've had a lot of issues with atazanavir getting the higher doses. There's data showing that if with TDF-FTC, we need to increase the dose from 300 to 400 milligrams in the second, some say, but definitely in the third trimester. And sometimes getting approval if they have insurance to get that can be challenging. More success with ADAP, but still it brings some challenges and also adds some pill burden to that individual. But we expect to have TAF, the tenofovir alafenamide, probably move up to preferred very quickly. But we also know in recent guidelines that anything that has cobicistat, so in the bottom right, has moved to not recommended because of the higher incidence of individuals having HIV viral breakthrough in the third trimester with these medications. Now, I know there's some data in the guidelines that says if somebody comes in, let's say on Stribild, can you continue it? Yes, but you need to monitor the viral load monthly. So your follow-up is more intensified if you're going to continue that regimen. So I'm not going to go into all the data from Botswana and go through all those studies and go through the history of it. Happy to answer those questions or to have that discussion offline, but this is the most up-to-date statement from the DHHS guidelines committee that says dolutegravir is now recommended as a preferred antiretroviral throughout pregnancy, so that's all 3 trimesters, and in women who are trying to conceive. We still need to do counseling and have that discussion, so there's not panic if they hear something from the pharmacist or hear something say, oh, this is harming my baby. We really want them to understand that data did not pan out and that it is safe to go ahead and give this medication. As I mentioned, possibly tenofovir alafenamide moving up as a preferred in pregnancy. This call comes from really a lot from the Impact 2010 studies. And there were some updates on the results in the CROI 2021 that really showed a couple of things. Around the world, efavirenz in the form of a tripla is still the most commonly used medication in pregnancy, but it really showed a couple of things. They did 3 arms, either TAF or TDF with dolutegravir or the tripla, and they really found that the dolutegravir containing arms were superior. Not non-inferior, but superior in virological efficacy. And the TAF regimen compared to TDF, either TDF regimen, had the lowest rate of adverse pregnancy outcomes. So really it kind of puts us to the forefront of maybe we should be using this in pregnancy. So it showed safety. Mortality was higher and virological failure was higher with the efavirenz arms. So hopefully from a world perspective, I know a lot of us are no longer using efavirenz. There are certain situations, if someone's co-infected with active tuberculosis, it's one of the drugs of choice, even though we now have other options. But really, this is something we can really think about dolutegravir TAF as part of the regimen in individuals who are pregnant. I want to mention quickly also, and I'm trying to be cognizant of the time because I know we also want to talk about pre-exposure prophylaxis, but if we're going to do a C-section, it needs to be done at 38 weeks if the indication is HIV. And as an HIV infectious disease provider, I feel very confident of putting in my note from an HIV standpoint, this client needs a C-section or can deliver vaginally. And I think it's important for us as specialists to make that comment. And I'll get back to that here in a second. But if the HIV viral load's above 1,000, it's unknown, if it's acute, if it's latent pregnancy, really we want to go ahead and do a couple of things. That would be an indication for C-section. If we're near the time of delivery, also we want to give IV zidovudine, AZT, which we would give a 1 hour loading dose at 2 mg per kg, and that's a continuous infusion. If there's going to be a C-section, we want to start that 3 hours before the C-section is scheduled, and then 1 milligram per kilogram for each hour until we get to 3 hours, and hopefully we start the procedure at that time. Otherwise, the OBs might come back and say, oh, but there's other indications for a C-section. I say, okay, if there's other indications, the viral load's less than 1,000, then that can be done at 39 weeks. And of course, then we want to give prophylactic antibiotics like we would for any surgery. But we still have a few OBs in our state that believe HIV plus pregnancy equals C-section. It doesn't. So we're doing a lot of training to say, here's the guidelines, here's the literature that shows we can safely do this. And if we look at the data that came out of Ireland, and this was the 2000-2006, I'm not going to show the 2015 data, so they extended this, but it showed if everything goes right, let's say mother knew about her HIV, diagnosed prior to pregnancy, always adherent with her medications, no issue with picking them up, no issues at home. She's always taking her medications. And you can see elective C-section was 0.7% and planned vaginal was 0.7%. And that data even looked better with the 2015 data that they had released following this study. So I think it's really imperative to understand this and show providers this data to say, look, it's safe to do this. Now, if there's other indications, I'm not an OB, and they say the OB indication for C-section is X, I'm not going to argue with you, as long as we're not saying, oh, it's absolutely due to their HIV in somebody who is controlled. The next few slides are really for your reference to look at, but to kind of look at this from a historical standpoint, since there were changes. I remember when zidovudine for baby was given 4 times a day for 6 weeks, and to finish that was really challenging. And a lot of my mothers just said, I just can't get the medicine down my child. I can't do this. I just can't do this anymore. But now we know it's twice a day dosing. If everything goes right, again, mother diagnosed early or prior to a pregnancy, on ARVs, adherent, virally suppressed, then it's 4 weeks, 4 mg per kg, Q 12 hours for 4 weeks. And we want to make sure that baby finishes that regimen. There's so often that someone else outside of our world will say, oh, your baby's test in the hospital before they were discharged was negative. You don't need to finish up this 4 weeks. Yes, you do. Or the second test was negative. You don't need to do any more. We can stop this. No, we need to continue the entire 4 weeks. If things didn't go as planned, there's adherence issues, diagnosis was latent pregnancy, those other factors, then we really need to give 3 drugs. So zidovudine 3-TC, medication like raltegravir can be given, which has been FDA approved in this situation. And we really want to go for at least 6 weeks, as we can see here. And we want to continue the evaluation as we normally would. And again, I'm not going to go through this, a very busy slide, but it's for your reference. Here are the doses for all of these medications. But going back to my comment where I've had pediatricians say, oh, you can stop that, we don't need to do that. Or they had a single test and mother didn't understand why they needed to bring baby in for another test. So if there's low risk, there's 3 tests that we want to give. And to make a diagnosis, there needs to be 2 positive tests. So we want mother to come in and we want to make sure that we do all the testing. And if it's a higher risk, then again at birth, and many times I have hospitals, they say whether the risk is low or high, we check it at birth. Okay, I'm not going to argue with you with that, but just don't make some major change in therapy based on that test. But you can see now, if there's higher risk, there are 2 added tests at birth and at 2 to 3 months. And what the guidelines say is that 2 to 3 month test is there to be done once baby has finished their ARVs and they've been off for 2 to 6 weeks. And some experts will go ahead, and I support this. You've done all these tests, it's negative. A mother might come in, hey, I'm still concerned. Well, when you get to 18 to 24 months, doing antibody antigen testing and going ahead and test baby at that point. Of course, we're not doing that too early because we don't want to test mother's antibodies. And here is just a quick snapshot. I think a little easier to look at when I'm showing this slide to new providers, or even to a mother, to say, look, you fall into this low risk or you fall into this high risk, and we need to make sure this testing is being done. Because in our state, we do have folks that go out and at least try to contact a mother if need be and get them into care. The other issue that I bring up, just to be aware of, know what your hospital is doing, because many times patients will get erroneous information when they're in the hospital by the educators or the staff. And I've had several folks say, "Oh, don't worry about your HIV meds. Just follow up with your HIV provider. They'll tell you whether or not you need to continue them or not." Well, there's dangers to that. Let's say the client is on that efavirenz, that a triple, and they just stop it. Well, we know TDF-FTC, based on its half-life, is out of your system in 5 to 7 days, but the efavirenz holds on for 30 plus days. So the virus sees monotherapy, and suddenly we have a K103N mutation, so that's resistance to efavirenz. Let's say the triple is just restarted. Now we're on dual therapy, and in this instance is not approved. We suddenly get an M184V. Now they're on monotherapy, and then they start to develop more and more resistance. Or the client's co-infected with Hep B. We just stopped their therapy, and suddenly they get a flare. There's been cases of fulminant hepatitis following this. So really the best advice, just continue that therapy unless there's a major side effect, but call us, let us know. I know folks, you send me emails, you might have something in the chat and say, oh, there is language in the current guidelines about breastfeeding. The World Health Organization has tons of guidelines about breastfeeding, and as long as they're on antiretroviral, et cetera. But in this country, the DHHS writers of the guidelines still feel, well, still avoid this. And we can replace this with affordable, feasible, acceptable, sustainable, feeding options. And we also want to talk about pre-mastication of food, because there has been a couple of cases of HIV transmission this way in this country. So just that needs to be a part of the education. I'm not going to go through vaccines in detail, except for just mentioning one of the newer ones. But the reason that I bring this up is I recently was doing a chart review at a clinic, and their vaccination numbers were really, really low. And I asked the provider, what's going on? You have issues with vaccine access, that's what's going on. And they made the comment, oh, I don't vaccinate individuals with HIV because it's dangerous. And they'd been doing HIV care for about 8 years. So I had to take a deep breath and let's pull up some data. It is safe to give vaccines in individuals with HIV. Now, there's some nuances we need to talk about, and you can see that here, some areas where it's not recommended when the CD4 count's less than 200, but we can do so afterwards. I notice here in pregnancy that we need a dose of Tdap with every pregnancy. And what I've seen is missed opportunities. The OB is assuming the HIV provider's doing it. The HIV provider's doing the OB, is assuming the OB is doing it, and nothing's getting done. So make sure that there's good communication. I mentioned Heplisav-B, the newest hepatitis B vaccine. It's only 2 doses, so adherence goes much higher than the 3 doses. And if you look at the bottom, this is a seroprotective rate. If you look at Heplisav-B, it's above 90%, no matter what your age is. Versus it drops with Injur-XB down to 72% if someone's between 60 and 70. So something to really think about Of course, this does not cover Hep A, but there's no studies in pregnant women. So if you happen to give it, somebody gives it, just register that with the pregnancy registry. Looking at, because we just don't have any data. That would be off-label use. And you can always call, local, you can call myself, you can call the National Consultation Center to have discussions about HIV and pregnancy. Some new guidelines: hepatitis B, HIV co-infection. TAF is an option for treatment. Hepatitis C co-infection, we do need with these direct-acting antivirals, since we don't have data, wait till postpartum. Hep C is not an indication for C-section, I say that again, not an indication for C-section. Tons of data to suggest you can go ahead and deliver vaginally if that's indicated. We talked about the dolutegravir counseling, and we need to promote PrEP and TDF-FTC specifically if someone's trying to conceive or pregnant, postpartum, or breastfeeding. That has made it into the guidelines. And of course, we do want to register with the ART Pregnancy Registry. And I'm going to get into that in really much more detail and look at a few more things. Just because this just came out here in the last couple of days, I want to throw this out, that congenital syphilis has nearly quadrupled between 2015 and 19, and 3/4 of all cases are due to gaps in testing and treatment. So we have laws in Georgia that doesn't fix it. We're still seeing syphilis. And in 2017, we had 23 cases. 2018, we had 27 cases. And in 2019, we had 33 cases. So we're going in the wrong direction despite laws, but we're doing a lot of education. And 2/3 of babies born with congenital syphilis were Black or Hispanic mothers. So lots of disparities. And that's one thing we're talking about today. I'm more than happy to come back and give a more in-depth discussion on HIV and pregnancy, but we're trying to cover two really big topics. And I do want to give a few minutes, hopefully, for questions. So let's talk about pre-exposure prophylaxis. And of course, the AIDS View does have information that you can obtain. I think it's really important to be able to look at up-to-date data, but keeping in mind that this is part of a comprehensive prevention plan. PrEP is not the silver bullet, meaning that I'm just going to give you pre-exposure prophylaxis and nothing else, because we know there are high rates of sexually transmitted infections that we're seeing. I'll show you a little bit of data that, but just overall, higher rates, the highest rates we've ever seen. The CDC just released that data that we've ever seen in this country. So it's really part of the discussion. And prevention itself is very complicated. So if someone comes in and says, I'm missing my appointments because of transportation, just handing them gas vouchers, sending a taxi, doing those things is not enough, I found most of the time. When they say they have issues with transportation, there could be abuse in the home. There's a single car that's being used as a tool to abuse that individual, not letting them use that vehicle with someone else in the home. There could be emotional distress. There could be housing issues. They're hopping from house to house. So there's all these other issues we have to really think about when someone says, I'm having issues with transportation. To remind folks, PrEP is FDA approved for heterosexual women and men, and there's also data growing in transgender women, which I'm not going to go through the IPREX studies during this discussion, but it's something we can still use in all populations. We really want to think more about exposure rather than race and gender when we're talking to individuals. What is their exposure? I had a young woman that nobody thought about HIV. She had lymphadenopathy. They kept thinking this was lymphoma, taking biopsies. They sent her to me for a final look. I diagnosed her with HIV. I was a young Caucasian woman, and her boyfriend was African American. Does that put her at risk? Well, absolutely not. But come to find out, boyfriend had 2 boyfriends, which he was having condomless, insertive, and receptive anal intercourse, and was diagnosed with HIV. So we have to make those connections and not remove the biases and the prejudices, and really start to ask questions about somebody's life and their exposure. So even though PrEP use has increased, that's great, 32% in 1 year. I mean, that's fantastic that we're seeing this. 94% of PrEP users in 2018 were men. So we're really missing the boat on a major population. And it found that there was lower PrEP use if you were African American, uninsured, low level of education. So we really need to reach populations in having this education. And also looking at transgender women of color in 2019, Black and Hispanic Latina transgender women represented 83% of transgender women living with HIV. So we can't ignore these other populations. Now in Ryan White centers, we're seeing an increase of transgender care, which is wonderful. So there's been a lot of education, a lot of things going on to improve this, but we do still have a ways to go, but I'm glad these arrows are going up and not flat or going down. So we know this is part of prevention. So we want somebody to be HIV positive. We want to verify that. Of course, we're not going to use the oral swab because that takes 3 weeks to become positive, again, on average. And so we're going to either use the whole blood finger stick or use lab tests if you can have a rapid turnaround to do this testing. And the guidelines say a negative test within 7 days. And PrEP with men is much more forgiving in missing a dose or 2 a week. But in women, what they found was really to have good protection, it requires 6 to 7 doses per week for women in PrEP. And that keeps their lower vaginal tract tissue levels at a high enough level for prevention. So it's really a lot of discussion. We want to have a discussion with folks in a very open way. It needs to be bi-directional. We don't want to be lording over our clients, sitting down when we have the discussion, having good eye contact, and really making sure that there is a safe environment that's non-judgmental and having open communication. And one of the things I will pull up, depending on the client, to show, there's risks depending on what we're doing. And someone might be having receptive anal intercourse, but they're also have substance use disorder. So we have to think about that. Are you sharing paraphernalia? Is this going to add to your exposure? So what does that look like? And what does acute HIV look like? Because part of this, when we talk about pre-exposure prophylaxis, we always ask the client, call us if you have symptoms of acute HIV and that looks like fever, fatigue, muscle aches. We don't want to use our terminology. We don't want to talk down to people, but the majority of folks I take care of, they would have no idea what myalgia, what that term even means. But the issue is with this, when you look at acute HIV, it can look like COVID, it can look like flu, it can look like other things. So we want folks to call the office, have a conversation, and look at that. And we don't have time to go through this in detail, but one of the things I will show folks is, if you look on the left, here's genital mucosa. Here's the exposure to HIV. Not all of it gets through the barrier, but there are founder viruses that will make it through. And suddenly we have replication and we have infection. And the way PrEP works is you start the therapy within 1 to 2 days. You do have it in the genital mucosa, and then within 21 days, and this is if you look at vaginal tissues, now we have high enough levels for protection. There is exposure. The founder virus makes it through, and it's blocking replication so you don't get infection. So I think it's really important for the clients to really understand why it's important to take the medications. But there have been breakthroughs, and I just mentioned that to say it has happened. And this is a few cases that came out in the Lancet, and they're kind of look to say, that's interesting that there was a breakthrough and no major resistance. Some of these with more major resistance, I can understand. I'm taking a medication and I'm having relations with somebody who's highly experienced in treatment, has a lot of mutations. It bypasses my meds because they don't work. So I could see that. But why are we seeing some that have no major resistance? So more data needs to come out. So we want to keep asking the question when someone comes in. Folks come in every 3 months. Is there ongoing exposure? Meaning that, my boyfriend is living with HIV. They're on therapy, they're undetectable, but I still want that. I understand U equals U, but I want that extra barrier. Or maybe I have someone on the side I'm having relationships with that I want to protect myself. But then all of a sudden I don't have, that lifestyle, those exposures, and suddenly I'm with somebody who is without HIV. I'm without HIV. I want to continue my PrEP 28 days beyond my last exposure, but then do I need PrEP anymore? Well, under that situation, no, but if I'm starting to bring a third party into the relationship, maybe I have substance use disorder I haven't disclosed, then we need to have those discussions. Because as we've discussed in the initial Kaiser studies, 43% of the folks on PrEP decreased their condom use. And in that population, 50% acquired another STI within 12 months. So it's still occurring. So we want to have this close follow-up. We want to follow kidney function. We want to make sure when they're stable on PrEP, they're coming in at least every 90 days. Do they need to continue it? Are we discussing about condom use and prevention of other sexually transmitted infections? So I leave this for a reference. I know we're running out of time, but I want to point out again here, immunization and also PrEP. The current PrEP that's FDA approved, whether that's Truvada or Descovy, does treat hepatitis B. So we want to make sure that we do that evaluation prior to starting the medication. And the other thing we want to talk about is I don't get a lot of side effects, headache, abdominal pain, weight decrease, and that comes from the TDF and Treva studies. The TAF studies show some weight gain. So we have to be cognizant of that. A couple of things on this slide is I tell folks if I put in my search engine pill 701, this comes up. So just be aware that if people get into your medicine cabinet and, you know, we live in a world of instant, I can put something on my phone and instantly get answers that we want to make sure folks are disclosing their lifestyle or their status when they want to and how they want to. 2018, we had FDA approval for PrEP for individuals who are 77 pounds or more. And know your state laws. In the state of Georgia, we can go ahead and treat for HIV, STIs. We can give preventative services without parental consent, but check your local laws. A second drug was FDA approved, so that's the TAF FTC, but it is not indicated for receptive vaginal intercourse. Does not have that indication. If you use it, it's off label. So just keep that in mind. It does take time for these medications to get to therapeutic effects in the blood, so in blood, cervical, vaginal tissues, rectal tissues. So be cognizant of that. And it is, and there's growing safety in pregnancy, and that's why the guidelines recently showed PrEP adding pregnancy language. And some folks might come in and say, hey, I want to use the PrEP on demand or the 211. And I say, well, it's only been studied in men who have sex with men. So we have to wait for more studies to come out. And I'm not going through some of this in detail due to time, and also because we're really focusing on women's health. So we have to understand the differences of what we can and can't use. So currently, the only thing that's indicated for PrEP in women would be daily PrEP with TDF FTC. Want to leave you with some resources before we get into possible future direction in being able to obtain these medications. Also, the Ready Set PrEP, the federal initiative, also helps with acquiring medications. So let's take a look at just a couple more slides, and we're going to finish in a couple of minutes, and I'll stop showing my slides to see if we have any questions. If we look at future direction, and this is data that came out in CROI 2021, I think this is really something that is exciting, but hopefully we'll have some next steps beyond this. And we're not going to go through this HPTN 8083 study in detail, but what this study showed, and again, men who have sex with men, transgender women, so no women in this study. So that is very typical of what we see with studies, and it's very frustrating. They looked at cabotegravir, the long-acting injectable, giving intramuscular. It was given every 2 months. So that is helpful, because a lot of the folks I care for, they say the every 4-week injection just doesn't work for their lifestyle. But this is every 2 months. And I think what's really interesting with this is it showed superiority. It was superior to TDF FTC. So this is really exciting data to say, wow, could we do prevention? You get an intramuscular injection every 8 weeks. We know your adherence during that time is at least 100%. There were missed doses during the study, which their individuals acquired HIV, but the folks that had that were taking the medications as such really showed good protection. And really, most of the infections occurred in the TDF arm, low adherence. There were 8 occurrences in the cabotegravir arm, again, low adherence. So adherence, counseling, communication is key. But there's other medications that are being looked at for treatment and then hopefully as prevention. Islatravir has multiple modes of action, and also the capsid inhibitor, lenacapavir, is being investigated. Currently, they're being looked at combined in being used for treatment. So imagine suddenly, instead of with the cabotegravir and rilpivirine, which is now FDA approved for every 4 weeks, the Atlas 2M studies, hopefully will extend that out to 8 weeks, but possibly if we had it every 6-month therapy, that would really revolutionize what we're doing. But as you can see in the bottom of the slide, when Croy, this comes out in Current Options in 2020, showed that could this also be used for prevention? And imagine now getting something that's sub-Q every 6 months for prevention would really revolutionize what we're doing. So I know that was a whirlwind tour, but again, it gives us a few minutes for questions. And please reach out if there's questions to, locally, to Sarah, to the national call line, to myself. I'm happy to answer those offline. So thank you so much. I'm going to stop sharing here and see if there's any